The broadcast is now starting. All attendees are in listen-only mode.
All right, good afternoon. It's Dr. Bill Smock. Welcome to our webinar. We'll give people just a few more seconds to log on. I see the numbers of attendees continuing to climb. So hang tight and we will get started on this fascinating webinar with Dr. Mike Weaver, friend and superstar clinical forensic physician. So hang tight, let's give us a few more seconds and we will be ready to go. All right, so this is Dr. Smock. Let's get started on our webinar. As the medical director for the Alliance for Hope and the Institute on Strangulation Prevention, I'd like to welcome you to this webinar on how do we evaluate the strangled pregnant patient. This is a question that comes up quite frequently in emergency departments across the country. And we want to fill you in on the research that has been done by the committee that looked at this, chaired by Barb Bachmeyer out of Indianapolis and Mike Weaver. We want to thank the Office on Violence Against Women for supporting the Institute in our efforts to bring training to police, prosecutors, defense attorneys, physicians, nurses across the world, and in particular the United States. So Katie Sullivan, the Principal Deputy Director, and Kevin Sweeney, our Program Manager, thank you very much for supporting this and endorsing the work of the Institute. We have a tremendous team behind the scenes that make all our educational offerings happening, from Casey, Gail, Trish, and Carly, who are listening in, but kind of the silent partners, and we could not do this without you, Trish and Carly. Thank you very much. The Institute is supported by the Department of Justice. We offer online trainings as well that are free, so please sign in, take those trainings as you have the opportunity, and the trainings are for advocates, police, prosecutors, and medical providers. The Medical Advisory Committee, we could not do this without you. We have physicians, nurses, researchers, educators from actually now across the country and the world, including Australia now. Is these healthcare providers that permit us to bring you the latest medical information on how to take care of victims who have been strangled. So thank you, Medical Advisory Committee, for your support. Gail always reminds us of why do we do this? Why are we passionate about evaluating victims who have been strangled? The memory of Cassandra Stewart and Tamara Smith are high on that list, and that is why Gail says we have to do a better job. And for me, this morning I got off the line with the wife of one of the police officers from Fort Wayne, Indiana, who stroked during their lateral vascular neck restraint training. You know, bad things happen when we put pressure on another human being's neck, including blocking or causing plaque to break off and block arteries in the brain, causing stroke. So that is why we do this, and we have to remember why are we concerned about these victims of domestic violence and assault, in particular strangulation. Mike Weaver, my dear friend, mentor, a national leader in clinical forensic medicine, and currently the medical director of the clinical forensic program at St. Luke's Healthcare in Kansas City. Mike, thank you for taking a deep dive into how to take care of a victim who is pregnant and who has also been strangled. So Dr. Weaver, take it away.
All right, well, thank you, Bill, and thank all of you for tuning in today. For those of you who don't know me, I'm an emergency physician in Kansas City, Missouri. Next slide. There you can see a picture of the skyline of downtown Kansas City. I don't know how many of you have ever been there, but on the very west side of downtown, next slide, you'll see a picture of a cow on a pedestal. And I know some of you think Kansas City is a cow town and wonder if this may signify that we actually worship cows, but there's another reason that we have this symbol. And it's because we love barbecue. So I invite any of you, if you ever get in Kansas City, please look me up. I'm a little barbecue confectionado and would love to share with you a little bit of our secrets of our town. Next slide. So let me give kudos to our Strangulation and Pregnancy Subcommittee, Sally Hennon, Ralph Avelio, Barbara Bachmeyer, Jennifer Johnson, Stacy Mitchell, and Annie Louise O'Connor. All of us worked together to put this presentation together for you guys today. And a special thanks, obviously, to Bill and Gail and Casey, and to Trish and the staff that's helping make this possible. Next slide. So it's been a while since the Institute has presented the adult non-fatal strangulation guidelines. And as a quick review, you'll notice up at the very top, we had the title, and then we had the goals in red. And then if you went down, depending on the results of your history and physical exam, you either went down on the left side of the box, and excellent, yeah, with all the history and physical, and then you went further down and you looked at all the radiographic imaging options. And then after the bottom box on the left, you went over to the right and discussed the discharged options. Next slide. And then on the back of that was the references. Next slide. So we wanted to use the basic same template for the pregnancy guidelines. You'll notice we did make a few little changes. We changed the title box. It's now in pink, so you could easily differentiate it from the adult protocol. And then, not to be sexist, we actually made the second box in blue to have a little bit of male representation. Next box. And we also had a appropriate literature search and the references specifically around pregnancy risk and benefits. So those are the top 11 articles there. And then we also reproduced the general references for the general non-fatal strangulation in adults. Next slide. So let's do a little deeper dive. So as I mentioned, the big change we made was in the not only in the colors of the first box and the second box, but if you look at the goals, that we added a fourth goal from what was presented in the adult protocol, that of being the evaluation and monitoring of the fetus. This is critical because now we're balancing both the risk and benefits, not just of the strangled patient, but also of the fetus that the patient's carrying. Next slide. So this next black bar that says strangulation patient presents to the emergency department, pretty much all we did is add the word pregnant to that bar. And then we had a very robust discussion about what was the appropriate next step after the pregnant traumatized patient arrived in the ED. And we learned that a number of members of our committee all had different ways of approaching this type of patient. In some institution, their protocol said that the ED doc would evaluate the patient. Some had protocols that said, you know, the ED doc and in combination with the OBGYN resident on call would see the patient. And then some had the ED doc and the OBGYN resident and the maternal fetal medicine doc come down and evaluate the patient. Some institutions, they activated their trauma team to evaluate the patient. And of course, in rural areas, they would just activate the helicopter and have the patient transported out. We also had some pretty robust discussions about determining the viability of the fetus. And again, this varied pretty much by by programs. Some, the ED physician was ultrasound trained, and he would do that scan. Others would call down an OBGYN physician or a specially trained nurse or a resident to do that scan. And of course, there's even discussions about, well, do you do an abdominal ultrasound or do you do a vaginal ultrasound? And that, of course, depended on the weeks of gestation. So we quickly realized there was a wide variety in the way different institutions in their initial response to the traumatized pregnant patient. And it would be impossible to design a one-size-fits-all guideline that would cover all of these granular circumstances. So we decided instead just to add another second black line recommending that institutions follow their established basic pregnant trauma patient protocols because we didn't want to disrupt the flow that had already been established. Okay, so then after that, we proceed down the left side, and the next box is all about the important history and our physical findings regarding the pregnant strangled patient. And again, we didn't make any changes here. It's exactly consistent with the adult guidelines in terms of the questions that you should be asked and how you should assess the strangled patient. All right, so let's go down to the next box. Next slide. All right, so this takes us into the pregnancy guidelines, which starts out the same way as with the adult imaging recommendations and starts with the CT imaging. And we begin with the gold standard, the CT angio. And in reviewing the literature, we found that the CT angio was safe for all stages of pregnancy and also in lactating patients. And we highlighted these changes in pink so that they would stand out. Also, much like in the adult protocol, we realized that a CT of the neck is not as sensitive, but also we realized that this would be safe for all stages in pregnancy and safe with lactation. So how do we know this? Next slide. So let's do just a little quick step back to Radiation 101. And if you look at the dose line, you know, the concerns about toxicity has to do with the amount of rads, which is the amount of radiation that's deposited per kilogram of tissue. So the term that we used to use is rad, now we use grays. And that's just a term that's more internationally accepted. The next line talks about relative effective dose, and that we're using REMS, the old term, now we're using millisieverts. And the idea is that when you're going to measure toxicity, the amount of radiation exposed to, let's say, bone would not have the same effect as it would, let's say, it was thyroid tissue. So you have RADs and REMS that have now been converted to grays and sieverts. And so when we go through this and start talking about toxicity, we'll be talking about grays and sieverts in terms of potential level of toxicity to an infant. You do need to understand that, in essence, a RAD and a REM are equivalent to a gray and a millisievert. Okay, so let's go to the next slide. So when we look at the gestational effects, based on animal studies and epidemiologic studies of survivors from the atomic bombs in Japan, the risk for radiation exposure has been divided into basically two stages, the gestational period and the fetal period, with substages in there. So if you look between 0 and 2 weeks after fertilization, the threshold you do not want to exceed is anything more than 50 to 100 milligrays. When you look from 2 to 8 weeks, that's when organogenesis is going on, and you want to avoid any higher than 200 milligrays. Then when you go down to the fetal period from 8 to 15 weeks, Again, thresholds where you develop toxicity is somewhere from 60 milligrays and higher, and then from 16 to 25 weeks, you can have intellectual disabilities if you're exposed more to doses, any doses higher than 250 to 280 milligrays. So the bottom line is that we really want to stay below 50 milligrays in any sort of diagnostic imaging that we use. Next slide. So to put all this in perspective, and this is developed by the Health Physics Society, which is the overarching organization that tries to monitor what we do and make sure that we minimize any risk to any patients. We realize that the average annual amount of radiation that we receive just from being here on the Earth is about 3 millisieverts or milligrays per year. So that by the age of 50, you've actually, or by the age of 17, you've actually already been exposed to about 50 millisieverts. And if you live to 80, you've already gotten to about 250 millisieverts. So looking at epidemiologic studies have not consistently demonstrated any adverse effects in persons exposed to small doses less than 100 millisieverts over any projected period of time. And in fact, levels below 100 millisieverts above background from all sources combined, the radiation effects in people are not significantly different from zero. So that actually gives us a little bit of comfort. Next slide. So the good news about fetal radiation. When you look at that, and we won't go over all these in detail, but in the top box, when you look at the amount of radiation exposure you get with a head or neck CT, it's 0.001 to 0.01 milligray. So that's far below the 50 that we would consider. You can see other examples here throughout the amount of radiation you get with abdominal radiation, with CTs for pulmonary embolus, very low box abdominal CTs or pelvic CTs, and even they just get to the very upper border of 50 milligrays. So the bottom line, and I will tell you, although not listed on this chart, a CTA of the neck is about 2 millisieverts. So you can see we're way below the threshold of any toxic damage. Next slide. And there's even more good news in that all CTs are not the same. So depending on the generation of the CT you use, the number of slices that you use, the pitch that you use, you can also minimize even that very low, if you're doing a CT A of the neck, even that 2 millisieverts that patients would be exposed to. Next slide. So CTA in pregnancy, the contrast that's most commonly used is iodinated media, very low risk of effects there. Iodinated contrast can cross the placenta and enter to the fetal circulation, but there have been no iatrogenic or mutagenic changes that have been noted, and it's actually considered a Class B drug, so that it is safe to use. Next slide. CTAs in breastfeeding. The American College of Radiology's guideline states that less than 1% of any iodinated contrast material is actually excreted in breast milk, and less than 1% of that would be actually absorbed through the infant's gastrointestinal tract. So mothers that are concerned about any effects, they can abstain from breastfeeding for 24 hours. with active expression and discarding of any breast milk during that period. But bottom line is that breastfeeding can be continued without interruption after use of iodated material. So the summary recommendations in terms of CT, both from, you see on the left, the American College of Gynecologists, and from the American College of Radiology on the right, feel that you need to go ahead and perform necessary examinations after clinical workup, and that iodated contrast material is safe in pregnancy. But you should counsel the patient and let them know if there are still concerns. There are things you can do with regard to lactation and other things that you can do with the CT machine to even minimize that low risk. Next slide. Okay, so now we'll get into MRI, MRAs. And we're first going to look at the first three bullets you see under the category have to do with MRIs and MRAs without gadolinium. And suffice it to say that an MRA of the neck, an MRI of the neck, or MRI, MRA of the brain are all safe to perform during all trimesters and for lactating patients. Next slide. So the American College of Radiology says there are some theoretical concerns about tissue heating and damage to the hearing of the fetus. However, published studies, there are no published studies showing harm, and preponderance of animal studies don't show any risk. No precautions or contraindications are specific to pregnant women during any trimester. There's no ionized radiation involved. And there's no changes with regard to breastfeeding. Next slide. So we know that MRIs with contrast can enhance diagnostic accuracy and imaging of the nervous system because they cross the blood-brain barrier. And in fact, they actually intentionally use MRIs to look at fetuses at times. Typically, the contrast agent that they use is gadolinium. That's the most common. And you need to know that free gadolinium is toxic, so it's typically administered in a chelated or bound form. And because of the toxicity, it's rated a category C in terms of giving it to a pregnant person. So it's interesting that in 2016, JAMA published an article of over 12 years with over 1 million patients from Canada. And they looked at what happened with MRIs with and without gadolinium. Next slide. So their conclusion was that exposure to an MRI during first trimester of pregnancy compared to a non-exposure was not associated with any increased risk and harm to the fetus or early childhood development, no increased incidence of stillbirths or neonatal birth, deaths, congenital abnormalities, etc. Can we go back? Yeah. All right. And then, but when they looked at gadolinium during pregnancy, if the contrast was administered, there was an increased risk of a broad set of rheumatologic, inflammatory, and infiltrative skin conditions, and increased risk of stillbirth or neonatal death. So that said, you know, probably shouldn't be using gadolinium. Next slide.
So, Mike, was that the gadolinium that was non-chelated?
Yes. Yes. So they again, the form, well, ultimately the form that they used was chelated, because that's typically the form that you use for all types of radiographic imaging, because we know that is the highest risk for toxicity if you don't use a chelated form. Okay, so the next slide talks about a study. Let's go back one. So this slide that's on the screen now just shows a study that was done in Oregon a year later in 2017. And this was actually done on rhesus monkeys. And just cutting to the chase, they only saw a very small amount of gadolinium in these monkeys after delivery. Next slide. So what was the difference? Well, what we found out, and in retrospect, that there are different types of gadolinium. And so the recommendation that it not be used as a Class C was actually based on doses that were 3 to 20 times higher than those clinically used. And also, as I said, there are different types. There are linear chelates, there are substituted linear chelates, and there's macrocytic chelates. And it's actually the macrocytic chelate that has the smallest risk of toxicity. And that was actually the one that they used in the rhesus monkeys. So next slide. So the water solubility of gadolinium-based agents limits their excretion into breast milk. It's very low likelihood after an ID dose after the first 24 hours. The infant, again, would absorb less than 1% from its gastrointestinal tract. So breastfeeding should not be interrupted after gadolinium administration. Next slide. So summary, with MRI with gadolinium, the use of gadolinium is controversial and should be limited. Use only if it significantly improves diagnostic performance and expected to improve fetal or maternal outcome. And of course, you should consult with your radiologist for those specific details. So again, there's some sorts of dissection like a carotid dissection that's due to vasculitis that could be distinguished by the use of gadolinium. So again, you'll have to weigh the risk versus the benefits. Okay, next slide. MRIs with the gadolinium is safe to use in all trimesters. When we look at going over to the box on the right, looking at consults with neurology and trauma and surgery, those haven't changed. When we look at continued ED, hospital observation, we have added that a lethality assessment should be part of that discussion. And indeed, if you decided to, moving up, discharge the patient home, that we felt it's very important to add a lethality assessment to the patient's discharge. Next slide. So, from a summary standpoint, the initial medical and radiologic evaluation of the pregnant adult patient should merge with existing institutional trauma in pregnancy protocols. The history and physical exam for pertinent positive and negative findings remains the same as in the non-pregnant patient. Imaging modalities recommended for the evaluation of non-fatal strangulation patients are safe for all stages of pregnancy and lactation, with the exception of an MRI with gadolinium, which is not recommended at this time. Lethality assessment should be part of the evaluation and discharge, and that we feel all patients discharged or observed for a period of time should have that lethality assessment as part of that, and discharge protocols should merge with existing institutional trauma in pregnancy protocols. Last slide again is just a picture of our pregnancy references in combination with the adult strangulation references, and all of these are up to date as of this year. We did a most recent literature search just before we went online. So there you have it.
Michael, thank you very much. And thank also to Barb Bachmeyer and to your committee for pulling together what I think is a fascinating and clearly a topic of interest, because the question comes up daily in ERs across the country: how do we effectively evaluate victims who have been strangled that are pregnant? So Michael, thank you. Thank you very much, and your committee. We will be taking questions. Dr. Weaver and I will be answering those. So please send those in from the website, and Dr. Weaver and I will answer those and get those answers out to you. A couple of follow-up things that I wanted to recommend. Sometimes we get questions about the use of ultrasound. The ultrasound cannot evaluate the vertebral arteries, and it has a very difficult time looking at the internal carotid, particularly up toward the base of the skull. I think it's fine for the common carotid, but you should not rely on ultrasound to say that that patient is safe to go home and doesn't have a carotid dissection, because it cannot evaluate effectively all those arteries that we need to see. And I think what's fascinating, what Mike pointed out, is that a CTA of the neck with only 2 millisieverts is way below that threshold. So emergency physicians across the country should not be hesitating to order the CTA for a strangled patient, because the risk of a thyroid cancer is theoretical, and only 2 millisieverts of radiation. Clearly, the benefits of determining is that patient safe to go home and that they are dissection free cannot be overstated, and the risk of the radiation is really non-existent. And then our Family Justice Center annual conference coming up in San Diego, we will have a record-breaking crowd. I know we have more than 650 people already registered. I think there are a few hotel rooms available at the Overflow Hotel. Please, this is going to be a fantastic conference with people from all over the world attending. There are multiple different tracks. So whether you're a police officer, an advocate, a medical provider, and a prosecutor, a defense attorney, a judge, we have something for you. Adults, children. I mean, this is a one-of-a-kind conference that you don't want to miss, because you have experts from all over the world, many different topics. I can't think of another conference where you get this many experts in one location, and plus the location in San Diego on an island. Come join us on the island. You can download from the webinar a certificate of attendance, as well as the protocol that Dr. Weaver and his committee have created. There are upcoming advanced strangulation conferences. The next one will be in Fort Worth in May. And on that fourth day of that conference, you can attend the forensic evaluation of gunshot wound course. It is an additional course, but if you were involved in the investigation of either domestic shootings or officer-involved shootings, come learn how you accurately determine entrance from exit range of fire. And you will learn that there are a lot of myths and misinformation out there. Most importantly, I think that size matters in the determination of gunshot wounds, and it does not. So, and then also in October, we will have another training in San Diego. So in memory to Cassandra and Tamara, this is why we are passionate about giving you the latest information, medical forensic information on how to care for our victims who have been strangled. And keep in your thoughts those police officers that suffered stroke during the LVNR training. They are recovering. One in particular is recovering slower than we would like. But when you put pressure on the neck, bad things will happen to you. And that's true whether you're a victim of domestic violence, whether you're a police officer. We don't want bad things to happen to you. And then again, thank you to OVW. We could not do this without you. Your continuing support helps victims of domestic violence and assault all across the country. So to Kevin, thank you for supporting us in this endeavor so that we can bring educational material and trainings to people across the country. So please submit your questions, and we'll do our best to answer those. Michael, do you have anything that you'd like to add before we sign off?
No, just appreciate everybody signing in. Sorry that we didn't have more time to get to your questions. This was our first attempt at trying to do a 30-minute webinar, and so we had to kind of rush through many things. But again, thank you all for attending.
Okay. Thank you, Dr. Weaver. Thank you, Trish. Thank you, Carly, for pulling this off. And I think that's it. Thank you very much for joining us.
Thanks, guys.